system.
Now take a really close look at this audiogram. What's super interesting here is just the sheer density of the posterior inferior cerebellar artery, or PICA branches, winding around near the bottom right. You can actually see the vertebral arteries combining there to form the basilar artery, right? Which then gives off the anterior inferior cerebellar artery, or AICA, and just keeps continuing up to the superior cerebellar and posterior cerebral arteries. But honestly, that PICA territory is notoriously complex, and mastering it is absolutely step one for us.
To truly master that arteriogram, and honestly, to spare yourself an hour squinting at an anatomy textbook, we've got to memorize the 5 distinct PICA segments detailed right here. We start with the M, or anterior medullary segment, and that's followed by the LM, or lateral medullary. Then, we hit the loops. And pay attention here because these are highly testable and clinically crucial. The TM, or tonsillomedullary segment, contains the caudal loop. After that, the TVT, or televotonsillar segment, which is also known as the supratelocellular segment, contains the cranial loop. Finally, the whole thing terminates in the CS, or cortical segments, and those branch out into the hemispheric and inferior vermian arteries.
Moving right along to Section 2, posterior cerebral artery segments.
Let's move upward. Our first segment is P1. So the really tricky point here is just knowing all of its alternate nomenclature, because it has a bit of an identity crisis. Depending on who you talk to, P1 is also called the mesencephalic, precommunicating, circular, peduncular, or basilar segment. It runs from the PCA origin directly over to the posterior communicating artery, or P comma. And you definitely cannot skip knowing its branches. This is exactly where the long and short circumflex plus the highly critical thalamoperforating arteries arise.
Let's see how this builds distally. P2 begins right at the origin of that PCOM-A we just mentioned, and it extends to the origin of the inferior temporal arteries. Alternate names for this one: ambient, post-communicating, or perimesencephalic. And why ambient? Well, because it literally traverses the ambient cistern. This segment is an incredibly important supply line. From P2, we get the hippocampal, anterior temporal, peduncular perforating, and medial posterior choroidal arteries.
Continuing on, the P3 segment is actually defined super straightforwardly just by its location. It starts right after the inferior temporal branches pop off, and it ends right where the terminal branches begin. Because it exclusively traverses the quadrigeminal cistern, it is, appropriately enough, known as the quadrigeminal segment. Easy, right? Finally, P4. This represents the absolute distal end of our PCA journey. It's the segment extending out after the origin of the parieto-occipital and calcarine arteries. So this section pretty much exclusively encompasses the cortical branches of the PCA, wrapping up our normal posterior circulation map.
All right, Section 3, Understanding Fetal Anastomosis.
Having mastered the standard, everyday adult anatomy, we're now going to explore what happens when fetal development doesn't quite follow the usual rulebook. You see, in utero, we have all these temporary connections between the anterior and posterior circulations. Normally, these fetal vessels involute. They basically just do a disappearing act in an exact chronological sequence. First goes the aortic, then the hypoglossal, then the primitive trigeminal, and finally the proatlantal. As the vertebral arteries and PCOMs develop, these temporary bridges just fade away, leaving the PCOM as the only normal adult anastomosis. But when there's a failure to involute, we are left with persistent fetal anomalies. While most are totally asymptomatic, they can occasionally be associated with tricky vascular anomalies like aneurysms, AVMs, or even cranial nerve symptoms.
This visual here just brilliantly illustrates exactly where these uninvoluted pathways connect. Looking at this cranial to caudal map, you can see the internal carotid artery, the ICA, directly connecting to the vertebro-basilar system via these persistence pathways. Notice from top to bottom there's the normal PCOM, then the trigeminal, otic, hypoglossal, and proatlantal arteries bridging the gap. And fun fact, the first 3 are actually named directly for their associated cranial nerves.
Let's zoom in for Section 4, the primitive trigeminal artery.
So let's dive deep into the most clinically significant variation of the bunch, the persistent primitive trigeminal artery, or PPTA. Honestly, if you remember only one single anomaly from this entire explainer, make it this one. Why is it such a heavy hitter? Well, it's seen in roughly 0.6% of all cerebral angiograms overall. Now, that might sound like a tiny drop in the bucket, but to put it in perspective, of all the persistent fetal anastomoses we just listed, an overwhelming 83% of them are PPTAs. It is by far the most common. It connects the cavernous carotid straight to the basilar artery, arising just proximal to the meningoa hypophyseal trunk. Interestingly, about half of them go right through the sella, while the other half exit the cavernous sinus and course right alongside the trigeminal nerve, which, you guessed it, is exactly why it can be associated with trigeminal neuralgia.
To truly master this, you absolutely must know the 3 Saltzman variations of the PPTA. In Saltzman type 1, the normal P commas are hypoplastic, meaning the PPTA is pretty much forced to do the heavy lifting, providing significant blood supply to the distal basilar artery, the PCAs, and the superior cerebellar arteries. Consequently, the native basilar artery is often hypoplastic too. In Saltzman type 2, the P comma actually steps up to the plate and supplies the PCA. And then there's the very distinct Saltzman type 3, where the PPTA unusually bypasses the basilar artery altogether and just joins directly into the superior cerebellar artery.
Now you might be wondering, why does all this hyperspecific anatomy matter so much in the real world? Well, because it completely changes the surgical approach. The anatomy of the PPTA creates massive surgical risks. For instance, if you don't recognize it before a WADA test, you run the very real risk of inadvertently anesthetizing the patient's entire brainstem. No way, we want that. Furthermore, because so many of these arteries course right through the sella, doing transsphenoid surgery without identifying a PPTA first invites a literally catastrophic risk of arterial injury. It can also be the rare, sneaky explanation for posterior fossa symptoms in a patient who, on the surface, only appears to have carotid disease.
Finally, wrapping up with Section 5, Other Persistent Fetal Arteries.
To ensure absolutely no stone is left unturned today and that your foundational knowledge is bulletproof, this matrix perfectly summarizes those remaining rarer variants. First up, the otic artery. It connects the petrous carotid to the basilar artery by passing directly through the internal auditory canal. Since it's the very first to involute in utero, it is the absolute rarest one to persist. We're talking only about 8 cases ever reported. Next is the hypoglossal artery. Originating usually between C1 and C3, it connects the petrous or distal cervical ICA to the vertebral artery. It crucially traverses the hypoglossal canal and, this is key, does not cross the foramen magnum. Finally, the proatlantal intersegmental artery. It connects the cervical ICA to the vertebral artery, with the anastomosis occurring way back in the suboccipital region. It's also incredibly rare, with around 40 cases reported. And interestingly, 50% of these patients present with a hypoclastic proximal vertebral artery.
So, let's bring it all together. Think about how these hidden anatomical shortcuts actually bridge the anterior and posterior circulations. They completely rewrite the established rules of vascular pathology. If a blockage is in the front, but the symptoms are showing up in the back, well, anomalies like the persistent primitive trigeminal artery are exactly what you need to be hunting for. Understanding both these baseline rules and the anomalous pathways challenges everything you look for on your next scan, ensuring you're never ever caught off guard. Thank you so much for joining me on this comprehensive deep dive through the posterior circulation.